Hello everyone. I don't know why it's not working now. Sorry. But this is the beginning. It's not working this video, it's okay. So I'm Belen Moliner from Instituto Bernabeu in Alicante. I would like to thank a lot Dr. Palumbo for giving me the opportunity to talk about the role for the ultrasound in assessing uterine peristalsis and its potential relevance in recurrent implantation failure. So, creo que no. It's okay. So, recurrent implantation failure is still a clinical problem that we face every day. So, even in the era of euploid embryo transfers, the pregnancy rate per embryo transfer is still far from the perfection. We don't have 100% of pregnancy rate. In fact, what is published by Jill and colleagues, for example, that they wonder if recurrent implantation failures still exist, they only reach per euploid embryo transfer 65%. And this is only ruling out patients with uterine pathology. So it means that they only include 75% of our patients. When we see or we are doing the embryo transfers in non-tested embryos, the pregnancy rates drop dramatically to 28%. So this clearly tells us that we still have this improvement that we need to do. So the question is not whether recurrent implantation failure exists, it does, but whether we are doing enough to evaluate and optimize the uterine factor. This is probably the question. So some authors have suggested that not monitoring the uterus before the embryo transfer might be acceptable in certain patients. However, continúo o cierro.
Necesidad de función. No lo está reconociendo.
So what we know so far is that the patients with recurrent implantation failure have more chance of failing again, even with euploid embryo transfer. From my point of view, is probably the opposite one. We are not in reproductive medicine to avoid evaluations, and we only are doing endometrial thickness to evaluate the uterus before embryo transfer. Now we know, and after all these speeches, that we can do a lot of things. We can evaluate the compaction, endometrial volume, 3D vascularization, 2D, elasticity, and of course uterine peristalsis. So uterine peristalsis started to be evaluated at the late 90s by Fanchini, Glambuletti, and others, into the ultrasound, of course. And what we know so far is that the high uterine frequency of uterine contractions seems to be associated to poorer outcomes in reproductive medicine. But the literature is inconsistent. In the 2017 meta-analysis, proposed a threshold of 3 contractions per minute. In the last meta-analysis published by Vidal, this threshold decreased to 2 contractions per minute. And in this comprehensive review that will be published in RBM Online in these few months probably, and the threshold range between 2 and 5 contractions per minute. Why is it so hard to establish this threshold? First, because the measure is subjective, so it depends on the operator. Second, because there is a lot of methodologies to assess the contractions. So there are authors that they assess during 1 minute, and others that they assess during 10 minutes. Authors that they consider one contraction when they see the contractions in both walls, another that the contractions are only when the direction is cervix to fundus. So there is a lot of variation of definition that what is a contraction. Also because they put together day 3 embryo transfers and day 5 embryo transfer. And what we know from the physiology is that in day 5 embryo transfer, the uterine contractions drops. So it guides us to wonder what is an abnormal uterine contraction. Mainly the Chinese groups try to define it. In this randomized control trial treating with atosiban, they started the randomized control trial, and then in the middle decided to assess uterine contractions and define the abnormal uterine contractions as, like you see, after 4 or 5 minutes, more than 4 contractions per minute, and direction fundus to cervix. They found around 22% of this population had abnormal contractions, but it doesn't fit well what they finally concluded or what they found. They concluded in this study that atosiban obviously didn't improve the outcomes of the treatments, but they saw that in these abnormal uterine contractions there are some difference, not statistically significant. Only was statistically significant in patients over 6 contractions per minute. So their definition really didn't fit well with the conclusion. Then another Chinese group, Su and colleagues, made this large cohort study in which they defined abnormal contractions when they saw more than 3 contractions in 1 minute. 1 minute is very, very low. So obviously only find 7% of the patients with abnormal contractions. When they did this propensity score matching, they found that atosiban really had some effect in patients with hypercontractility, which it makes sense. The problem is the methodology, how they assess it, and the define of abnormal contractions. So it guides us to wonder what is a normal contraction. The contractions are physiological and change through the menstrual cycle, fulfilling purposes. First, during menstrual cycle, the contractions must be fundus to cervix, to help the sheathing of the menstruation. This is led by the lack of progesterone. Then in the late follicular phase, when you have the peak of estradiol, the contractions change to cervix to fundus to help the transport of the sperm to reach the fallopian tube. And this is, as I told you, led by estradiol, but also by oxytocin probably. And then during the window of implantation, we need this quiescence. We need that the uterus be quiet to allow the embryo implantation. And this is led by progesterone and probably with another secretory products of corpus luteum. So the problem is we don't know the intensity, we know the direction, but don't know the intensity. And now we manage the uterine contractions depending on the time that you are assessing them. So what it makes the contractions abnormal? Okay, this paper really concerned a lot to the doctors that we are assessing uterine contractions. Anderson in this paper published that doing ultrasound might have some effect in the uterine activity. They assess the uterine contractions through MRI and with a surface electromyography. And it's possible that we are doing some activity in the uterus during the ultrasound. However, we don't have to forget that we have 2 types of myometrium, the neomyometrium and Artke myometrium. Neomyometrium is the surface of the myometrium, the external wall, and they have totally different origins. So the neomyometrium really has some is named non-hormonal muscle fibers, but it's not true because really they are affected by oxytocin, but also by mechanical stimulations. So, and the junctional zone, which is the archimyometrium, the origin is Millerian, and all the receptors are from the estradiol and progesterone. And this is the contractions that really affects the implantation. So probably what Anderson are assessing is not only the junctional zone contractions, it's also assessing the another ones. And it's possible that we are making some activity in the uterus, but it doesn't seem that this is affecting the pregnancy rate. In fact, I take out this data from the randomized controlled trial that I told you before, because they had some patients which they assessed the uterine contractions and another patients that they didn't assess, and finally the pregnancy rate was the same in both of the group of the patients. So yeah, it's possible that we are making something, however, it doesn't mean that it will affect the pregnancy. Anyway, the problem is all the groups are doing 2D scan, but I'm doing 4D scan. And probably it has even more effect in the uterine activity. So this leads to that we analyze our data. So we have until 2025, because we didn't assess 2026 yet. We had 901 ultrasound assessments. And one part is part from a clinical study. And we had finally, because we didn't have all the complete data, we had 751 with complete data coming from 604 patients. All of these patients are high-risk patients. If you see, the average age is over 40. The number of embryos transferred is almost 4. And the prevalence of uterine factor is 60%. The egg donation is done in more than 60% of our patients. And even with that, the average of uterine contractions is 1 contraction per minute, much less than we can see in other groups. However, it's true that we are assessing the contractions during 6 minutes in 4D ultrasound. If you see the outcomes, finally we have almost 48% of pregnancy rate, but the problem is that the pregnancy loss is very high, probably because we have 60% of uterine factor. And the live birth rate, that's why, become to very, very low, 26%. But why we did that? Because before this, we performed this observational study in which we assessed multiple ultrasound parameters. And the only associated with pregnancy rate, with biochemical pregnancy rate, was the uterine peristalsis. In a post-hoc analysis, we saw that the patients that had less than 1.5 contraction per minute obtained a pregnancy rate of 78%, and over 1.5 contraction per minute had 50%. And when we analyzed that, we saw that we had a reasonable sensitivity and specificity to make this a preliminary clinical study in which we only considered recurrent implantation failure or bad prognosis patients for treating with atosiban. That's why when we evaluate the patients with over 1.5 contraction per minute, we had 251 assessments in 205 patients. And we didn't see a lot of differences in the descriptive analysis, but I can tell you that there are few signals that really are consistent and we see in our daily practice. First, practically all the contractions, hypercontractility is seen in patients treated with artificial cycle. So probably it's because natural cycle is protecting with these secretory products to having these contractions, or because the artificial cycle can make this hyperestrogenism and even low progesterone. The another thing that we have seen that is a trend because it's not statistically significant is patients with endometriosis usually have more contractions. It's true that it's not significant as you see, but it's something that we feel and we always see in our daily practice. And then finally, and the most important, because it fits very well with the physiology, is consistently we see more contractions in patients with lower progesterone. And it also helps us to think that really probably we are assessing well the contractions, because if it fits well with the physiology, probably we are doing something good. When we move to the outcomes, the message is simple. Finally, atosiban does something. We don't know really what, but we statistically, in patients with hypercontractility that we treated with atosiban, had better pregnancy rate, statistically significant. However, again, we had more pregnancy loss, early pregnancy loss, and that's why we didn't see these differences in live birth rate or ongoing pregnancy rate. Taking into account that we saw in over 33% hypercontractility, we wonder if really we are treating patients broadly. That's why we assess the different thresholds. And what we saw is that really, if you see the columns, you can see that in patients over 2 contractions per minute and even 2.5 contractions per minute, the pregnancy rate is becoming higher. And the pregnancy loss is still an issue, but the most important is that we can see how the ongoing pregnancy rate and live birth rate is increasing too. The problem is in patients over 2.5 contractions per minute, really the sample size drop, and with that you lose confidence. Well, at this moment, we had this crossroad in which we had observational data suggesting that peristalsis matters, a clinical data suggesting that atosiban improves pregnancy rate, and really a real impression that high uterine contractions may identify patients that really have benefit. So we wanted to know really which is the best threshold to treat the patients, or who of them had the best benefit. No? The problem is the data were not randomized, and that's why we started to run the counterfactual analysis. So counterfactual analysis, the goal is simple. We wanted to answer the question of what have happened to these treated patients if we haven't had treated. So what happened? And well, the red one, is the counterfactual analysis. It tries to predict what have happened in these patients in pregnancy, in pregnancies, in percentual points. Sorry. So what we see is that in uterine in over 1.5 contractions, we can see a good benefit, but mainly in the biochemical pregnancy rate. We cannot see it in the ongoing pregnancy rate or live birth rate. In 2 contractions per minute, we can see that the ongoing pregnancy rate increased and the number needed to treat also decreased, and even the live birth rate. In patients with uterine contractions over 2.5, the problem was that in our observational study, we had practically 1 or 2. So the analysis really wasn't confident. That's why from 2026, we decided to only treat patients with uterine contractions over 2 contractions per minute, because if this is acceptable, we can increase the pregnancy rate of these patients over 30%, the ongoing pregnancy rate, which is a lot. So if you consider NNT treating, you need to treat 3 patients to have 1 pregnancy more. That, well, it's hopeful and it's perfect. However, the problem is not that we have our threshold, but even after all these years, I'm assessing contractions more than 10 years. I'm not confident 100% in all the assessments, to be honest. And there is a lot of limitations. It's time consuming, it's subjective, and what it for me drives me crazy is that I always see a lot of movements inside the endometrial cavity that really I cannot understand, but I know that they are important. Even more important than the waves of the contractions, probably, because it's where the embryo implant. So that's why another groups try to make this automation of the uterine contractions, which is perfect. However, the problem that they have, well, I've been in touch with Shoot, for example, the group of Shoot, that they published more, because my interest is to try to assess the uterine contractions in whole the uterus. If you are doing only 2D, you are missing probably 80% of the uterus, and the uterus is moving whole, not only one slide. So, and it was impossible because they have this semi-automatic measure, it's not automatic, they don't have automatic cementation. And that's why it leads me to ask what I need. I need an AI tool that able to make this segmentation, automatic segmentation, able to tell me what is an abnormal contraction associated with outcomes, what the patterns that can be associated with different pathologies, to assess the movements inside the endometrium. So because I'm a little bit crazy, I guess, I did this Master of AI with this objective. And I had the opportunity to work with the computer science department of the Universitat Autònoma de Barcelona, and the coordinator of my final work helped me to develop this initial or first approach of this segmentation. And we were able to obviously to assess the contractions. The contractions here we define differently, because one of the questions that she asked me was, what is a wave? A contraction is not something which decreases the volume, and it's true. We are assessing the contractions like waves, but these waves might have to do something. So we defined a contraction when we decrease the volume, because finally we make or we predict the volume according to the endometrial thickness and the endometrial cavity. When the volume decrease more than 10%. And with that, really, we had these 2 videos. It's only 2 videos. We are improving the algorithm, and we could assess the contractions and all these parameters that are perfect. Also, in the new algorithm, we are assessing the elasticity, which is also helpful, I guess. But the most importantly, after we use an autoencoder, well, another algorithm, we could separate the endometrial movements, and it was very exciting because, well, we defined the movements, all the movements that really was inside the cavity and had some coherence or coordination. We needed some coordination for that. And really was amazing to see how the movements sometimes are going to the same place. And we assess also all the parameters of that, and probably this is very challenging, but we do this for the reconstruction from there. And well, why now I think, or what I'm dreaming of, not only to improve the pregnancy rate of the patients that I see every day, that I try, also that I think all this information can help to those investigators that are making this in vitro endometrium. I had the opportunity to talk with Dr. Samuel Ojos Negros, who they saw that the endometrium who had more stiffness had better implantation. So I think if we can provide them these movements elasticity, velocity, everything, vascularization, we can reach this endometrium in vitro that can help to make this implantation in the future. But this is a dream probably. Okay, so my message I think are clear. I think it's worth to assess the uterine contractions in patients with recurrent implantation failure, but probably with all the patients. We don't need to wait. And these increased uterine peristalsis are associated with poorer reproductive outcomes, it's true. Atosivam, it seems that improves the pregnancy rate, so it's not needed to treat everybody. We need to assess uterine contractions and then treat atosivam accordingly. And obviously we need this AI tool to assess that everybody will be able to assess the uterine contractions. And that's it.